Good afternoon. Can y'all hear me? Okay, because I cannot see this side of the room. I'm that short and these monitors are just blocking everybody. So we're just gonna go with the flow here. You guys are good. Welcome to officially day one of NACFC. For some of us, I feel like we're already knee deep in NACFC already. So this is exciting. I love the weather. So this is sort of a part two of last year's NACFC because of backed by popular demand, we're having part two this year on the changing faces of the physical and respiratory therapy in the era of the highly effective modulators. So how exciting is that? So Maggie and I, again, are chairing the session, and Maggie, she has a new title. It's Young Grandma as of this morning.
Thanks.
In addition to all her other alphabet soup. and my name is Cheyenne. I'm from Austin, Texas, in the Dell Children's Pediatric Program. And Maggie is from the University of British Columbia, Cystic Fibrosis in Canada.
Thanks.
Okay. We have no disclosure for this presentation. So like I said, this is part two of last year. With the change of the highly effective modulator, there's just been a really big shift in our discipline. So we want to follow up from last year and re-examine the continuation of airway clearance and then the inhale mucolytics. And then the paradigm shift exactly, in our physical therapy, because now they're taking forefront, in addition to our traditional airway clearance. And then also other new things such as embody for body composition that, we might want to look into in the future. So the objective for this session is to describe these changes that we mentioned before with these daily treatment. And we want to appraise the literature also on these inhale medication, airway clearance, and our role in general. And then also discuss the effectiveness of exercise in a, primary form of airway clearance, and then also how it affects with the body composition and lung function to the extent of these modulators. Okay. I don't know why this is blank, but we're going to start. So we're going to do some housekeeping stuff. If you haven't done so already, you can do one or two things when the session's after each of the speaker. You can come up to the mic here and do the traditional way, which we didn't have last year. This is great. And you can ask the questions that way. And then, or you could do it on your cell phone. So if you haven't done this, you go to your cell phone and you look up our session, which is Symposia 10. And if you don't know how to do that, you go to Thursday and you look up S10. And then you're going to click on S10. And then you're going to get to this lovely page where you can see Maggie and I. But in the bottom, there is a Q&A section because there's a chat thing and there's a Q&A. If you put your question in the chat thing, no one's going to see it. But if you want to ask a question, it's in the Q&A section. And then you're going to get to this kind of a blank page. However, you want to click on the Ask Question button, which then will take you to this page. You're going to type in your question in the said box. And please remember to press Submit, because last year we didn't read your question. Well, you got to press Submit, guys. So it could pop up in the handy-dandy iPad over here for me to see. Okay? So now that we all know how to ask Q&A, I'm going to go ahead and start with our first speaker, which is Karen Womberg. She is a physical therapist from the Northeastern University at Johns Hopkins Hospital. She's going to start us off with To Inhale or Not to Inhale, part two. I'm like, where's Karen? I can't see you. You can choose to use this, or you can use into.
Okay.
Okay. It's up to her.
Okay. Yeah, it is weird with this monitor here. Hi, everybody over there. I'll see you again in 20 minutes. So as Cheyenne mentioned, I am doing part two. Part one on To Inhale or Not to Inhale was done last year in Philadelphia by Maggie. And my disclosures here, I do have one financial disclosure. And I would also like to disclose I am not a specialist in inhalation therapies, nor am I involved in any of the studies that I'm going to be talking about today. So be kind with your questions at the end. I am just a PT who had the opportunity to moderate a webinar on this same topic earlier this year, and then was invited by Maggie and Shinan to be here today. So thank you for the invitation, and I hope I can do this topic justice. Woe to the child who tastes salty from a kiss to the brow, for he is cursed and soon will die. Fortunately, so much has changed since this quote. And before we take a look at where we are now, where we may be in the near future, let's take a quick look back. The CF story really began less than 100 years ago. Dorothy Anderson, who, by the way, was a 1926 Johns Hopkins Medical School graduate, first described CF in a paper that was published in the 1930s. The 1950s brought a group of concerned parents, which started what is now known as the CF Foundation. The 60s brought 4-year-old Richard Weiss, who overheard his mother trying to raise money for him and his 2 brothers who all had CF, and he mispronounced cystic fibrosis as 65 roses. 89, we know that's when the gene was discovered, and then the 90s forward brought all kinds of great medicines and treatments, the VEST, Pulmozyme, the TDN, which is the drug development pipeline, enzymes to help with nutrition, all kinds of great stuff. And then the last decade, and really just the last few years, is where we have modulator therapies that are really, bringing us to the question of, for those eligible for modulators, do we really need all of those other treatments that came about in the 90s and beyond? So this brings us to the focus of this talk, which is to inhale or not to inhale. For physio and respiratory therapists, inhalation therapies have been a cornerstone in CF care alongside airway clearance. However, in the presence of effective modulators, what role does inhalation therapy play? If the CFTR protein has improved function and the airway environment is modified with less sputum volume, reduced sputum tenacity, and an environment less attractive to opportunistic pathogens, is inhalation therapy still indicated? Having worked with people with CF for more than 20 years, I've seen relatively healthy kids get by with doing few of the recommended treatments, grow up to become adults who get quite sick. Or maybe some have remained healthy. And I have to wonder, for those on modulators discontinuing treatments, will it last? How long will it last? Will they have a decline in lung function? And how do we know who will remain stable and healthy on modulators and who may decline? So a quick look at some of the data. These graphs are from the CF Foundation's Patient Registry Annual Report, comparing people on inhaled medicine in 2020 to 2021. And just to quickly orient you, the dark gray bars represent people on 1 inhaled medicine, the blue represents people on 2 inhaled medicines, and the red represents 3. And what stands out to me on this, what's kind of obvious, is the red bars. That's what, without analyzing every little bar, there's a bit of a drop, a good, recognizable drop in those on all 3 medicines, that being Dornase alpha, hypertonic saline, and an inhaled antibiotic. This doesn't differentiate which meds are not being taken, but it gives us a picture of what's going on, that people aren't doing as much of the inhaled medicines. This table breaks it down by medicine, and this is comparing 2016 to 2021 for people age 6 and up who are taking an inhaled antibiotic or an inhaled mucolytic. And if you'll note, the top 3, the antibiotics, there's a bit of a drop from 2016 to 2021. People are healthier, taking less antibiotics. Doesn't tell us why. Maybe it's because they're on a modulator. Maybe it's because we had that global pandemic where they were exposed to less viral load. But what hasn't changed all that much are those daily mucolytics. Maybe people aren't quite ready to drop or decrease them. Again, just not sure from this slide alone what's going on. But what we do know is there are numerous studies underway to help guide us and our patients as we make decisions about whether or not people with CF still need to do all of these meds on a regular basis. These are some of the studies that we are going to talk about in the rest of this talk. And we'll start with NEMO. NEMO is a mouthful to say, but I'm going to give it a try. National Efficacy Effectiveness CFTR Modulators Optimization Program. So this is a multi-center, 5-year observational study of adults who are prescribed ETI. 15 centers in the UK are involved, and these centers are also part of CF Health Hub, which is a digital self-care and behavior change platform that provides real-time objective adherence data to both the people with CF as well as clinicians. And this QR code, if you want to scan that, that'll bring you to CF Health Hub, or you can just go to cfhealthhub.com to learn more. The aims of NEMO are to determine the effect of co-adherence to inhaled therapies on FEV1 decline amongst adults prescribed elexacaftor, tezacaftor, ivacaftor, from here on out, known as ETI. And they're also exploring the difference in the co-adherence to inhaled therapies before and after the start of ETI. They're analyzing data from both 6 months before and after Kaftrio or ETI initiation, and then at 12-monthly intervals up to 5 years post-initiation. And that table there includes some of the variables they're looking at. To date, they've done a preliminary 2-year analysis of over 1,000 participants on ETI, and they've grouped their cohorts according to how adherent they are. I believe it's 4 different groups, from highly adherent down to not very adherent. Year 1, they didn't see much difference in percent predicted FEV1 between those highly adherent to inhaled therapies to those with lower levels of adherence. But the trend in year 2 is in favor of a higher FEV1 for those with consistently high adherence to inhaled therapies. And you can hear more about what they've found so far at either poster 613 or the Saturday workshop 35 on the de-escalation of care. Tracy Daniels will be there presenting more on her data with this. The next study I'd like to talk about is the home-reported outcomes, or HERO2 study. This is similar in that it's a prospective, observational, real-world research study aiming to characterize the range of outcomes people with CF experience while on ETI. This involved no research visits. They got all of their data from the Folia smartphone app, where people were asked to track their chronic daily therapies, their symptoms, and also to complete patient-reported outcome questionnaires. HERO2 will then compare that data in Folia to the CF patient registry data to look at outcomes such as FEV1. And 860 participants have enrolled. This is an outline kind of what the study looks like. So they're using patient registry data from a year before the start of ETI and then on through the 12 months after the start. They do phone calls every 3 months, and then the Folia app is looking to do daily tracking of what treatments they're on, what symptoms they're experiencing, and then a monthly survey. The enrollment or the Folia data, they stopped collecting in September of this past year. So we'll have to wait until we have the registry data from 2023, which will be about next year this time, so they can do that comparison to the outcomes such as lung function. But based on what they have from Folia so far, the graph on the left shows what type of chronic daily therapy was discontinued. So airway clearance, Dornase saline, inhaled antibiotic all had about 20% of the participants stop taking it. The chart on the right looks at how many chronic daily therapies people discontinued. So 0 therapies were discontinued by about 60% of the participants. And then you can see further on down, 1 therapy was discontinued by 14%, and so on down the chart. So again, more will be coming on this when we have the registry data to compare the Folia data to. Another observational study is Canada's Impact CF. Again, this is a prospective observational study with the aim to understand the long-term clinical impact of CFTR modulator therapy. So far, they've enrolled 206 people with CF age 6 and up who are on ETI from 13 CF centers in Canada. And this is a 5-year, so again, another long-term follow-up study. Some of the primary outcomes that Impact CF is looking at the change in FEV1, CFQR, which is a quality of life measure specific to people with CF, and then some mental health measures, the PHQ-9 and GAD-7. And we look forward to more to come on the results of this study, as well as HERO2 and NEMO to help guide us. Next, I'd like to transition into the studies that are looking at withdrawal of treatments. While as these first 3 were more, what are people doing on their own? Now we'll look at when they're asked to either continue or discontinue a treatment. And the first one we'll look at is Simplify. Simplify was done here in the US, and it was a 6-week study. To enroll in Simplify, people age 18 and up were included if they had an FEV1 greater than 60%. Between 12 and 17 years of age, they wanted them to have at least 70% FEV1. They were also looking for people who were at least 70% adherent to therapies. When they enrolled, they either went to the saline continue or discontinue group or the Dornase alpha continue or discontinue group. And participants did have the option to roll over from one study to the other once the first 6 weeks were completed. For enrollment demographics, it was similar across all cohorts for both saline and Dornase alpha, both the continue and discontinue. But the one that I really want to point out here is the FEV1. Look at that mean FEV1 for each group, 97%. So these were very healthy people who were very adherent to their therapies, so at least 70% adherence and 97% lung function. So pretty healthy people here. So let's take a look at what they found at the end of 6 weeks. The graph on the left is for hypertonic saline, with the lighter blue line being those who discontinued saline, the darker blue line being continued. And the same holds for the one on the right, which is specific to Dornase alpha. The brighter orange color is discontinue, while the darker line is continue. And you can see those lines are pretty close together. And you may also note that the continued Dornase alpha group winds up a little bit lower FEV1 than the discontinued group. But nothing was meaningful, no statistical significance with any of these numbers. So we learned that among those 12 and older with relatively good lung function on ETI, discontinuing daily use of either saline or Dornase for 6 weeks did not result in meaningful changes in lung function. A smaller cohort of these participants also had lung clearance index measured, and no clinically meaningful change in LCI was found either, in addition to some other key endpoints such as CFQR, pulmonary exacerbations, antibiotic use, and hospitalizations. Again, no significant findings there. But the investigators of Simplify didn't stop. There's more coming soon. There are sub-studies looking at lower lung function, as well as a longer term, 24 weeks. So now we're looking at 6 months versus 6 weeks. And they didn't want to share their data with me because they're presenting it later this week in that same Saturday session I mentioned where Tracy Daniels is going to be with NEMO. So if you want to hear more about these longer term and lower lung function studies, be sure to check out the other sessions this week. And the last one I'm going to talk about is CF Storm. CF Storm has a number of similarities to Simplify in that it was either continuing or discontinuing Dornase alpha or hypertonic saline. Key difference, it was done in the UK, not in the US. And I've bolded some of the other main differences here. One of them being that they enrolled participants with an FEV1 as low as 40%. So definitely looking at a different cohort with more moderate, to severe disease compared to, moderate to very, very mild disease in Simplify. Their baseline assessment was taken from routine clinic visits. There were no separate study visits for this study, which is another key difference from Simplify. They primarily used clinic visits and the patient registry. Participants were also asked to complete electronic survey, and the clinic team was asked similar questions on if participants were complying with the trial allocation. Primary outcomes here, again, another big difference. They're looking at FEV1 from baseline to trial end, which is 52 weeks, so a full year of either continuing or discontinuing a mucolytic. And they're also including home spirometry numbers, so looking at longitudinal patterns of change with home spirometry. Does that make you happy, Erin? I got some additional information from CF Storm just yesterday, so I want to make sure I include that as well. They have over 400 participants who are recruited in the 12-plus age group. As of last week, they now have regulatory approval to recruit in the 6 to 11 age group as well. So we'll have a younger cohort of people with CF, and recruitment is due to be completed in June 2024. So hopefully more to come on this, and if we have a part 3 next year, right? So that brings us to my last slide. And the message here is stay curious. My gosh, what exciting times we are living in CF now. Go to all the sessions that your brain can handle. Check out the posters. Get on the listservs and talk with your colleagues. I really think the clinical pace is moving a lot faster than the published research can keep up with. So we really need to work together and talk with each other and figure out what's best for our patients. How are we assessing and managing symptoms? Are we doing it at a frequency that meets the patient's needs? How frequent are we following up? Are your patients coming to clinic less because they're feeling better? I know ours are. Are we doing telehealth and phone visits to supplement and make sure that we know what's going on with our patients? Are we taking into account severity of disease prior to modulator? Are we dealing with someone who was on the lung transplant list and now is feeling great? Well, their grade is at a different threshold than some of those participants in the Simplify study, right? And, probably the most important thing is that we take into account the priorities of the person with CF. We need to be asking them the questions. What are your thoughts about continuing or discontinuing? How are you feeling about this? So ultimately, we can come up with an individualized care plan for each and every patient. Thank you to all of the study investigators who shared information, shared data. Some of them even put together the slides for me. And a shout out to my home center of Hopkins, who's always supportive of what I do. I hope you guys have a great rest of the conference.
Thank you so much.
Again, remember, if you want to have questions, you can step up to the mic in the aisle or do the app, which hopefully it will pop up on my handy dandy.
Yes. Thanks. Yes. Yes, so please come up to the mic or, as I said, use the app. And while we're waiting for that, I think it's really important what you said, that we have to distinguish the difference between those with mild disease and those with more severe disease. This morning, Scott Donaldson in Workshop 10 actually presented some more results from the Simplify study. And he actually showed that in looking at a subgroup of mucociliary clearance in patients who actually continued with their DNAs had a fall in decrease in mucociliary clearance. And so that makes us think, are we having detrimental effects with keeping on some of these therapies rather than stopping it? And so I asked him, what does he recommend in his patient population? And so again, just like you said, he said that in his group of patients who've got mild lung disease, he has a discussion with them whether they should stop or continue. And I just want to know, what are your thoughts about that?
I think you can't go wrong with asking for the patient's or the parent's opinion. To think about, somebody may have 106% lung function, but they may have had an uncle who passed away from CF. So they're really scared about stopping any treatments. And we need to take things like that into account. We also need to be, if they are stopping or continuing, we need to be asking the questions about how they're feeling.
Yeah.
And, not assuming that everyone with good lung function is okay to stop, or everyone with bad lung function, not bad lung function, but lower lung function needs to continue.
You're right. Okay. I'm just going to ask for a show of hands. How many people in their clinic have had it? I mean, we've all had discussions with our patients, but how many of you have actually told your patients they can stop doing? We'll start off with Dornez Alpha. How many people? Up your hands. Okay. And how many people have actually told their patients, and these are, we'll talk about mild patients, okay? So like the lung function in the 90s and no cough or sputum. How many people have said to their patients that they could stop hypertonic saline? Okay, so we get more. So, okay, so, I mean, this is still, an unfolding story as we go along, as we learn more and more. And I think that's why it's going to be important to get not just the 6-week study with the Simplify, but the longer term studies. Yeah. Do you have a question there?
Yeah, we have one question. It says, do you know of any retrospective analysis looking at discontinuation of airway clearance therapy?
I didn't hear all of it. Looking at what?
Do you know of any retrospective analysis looking at discontinuation of airway clearance therapy?
I don't know offhand.
I have not heard of any studies looking at that. Melissa is going to talk about airway clearance in the next session. I'm not sure whether Melissa has any ideas on that.
Maybe we'll find out soon,
Yes.
but I don't have an answer.
Right.
Okay, well, maybe that's just a good transition.
Thank you all.
Right. Thank you very much. Okay, so moving on, just as we were talking about airway clearance, our next speaker is Melissa Richmond. Melissa is a physiotherapist that works at BC Children's Hospital, I have had a pleasure of working with for many years. And Melissa has done her master's in physiotherapy, and she has been involved in quite a number of clinical trials, particularly looking at LCI as an outcome. And Melissa is going to talk about airway clearance through the ages, looking back and looking forward. So welcome.
Thank you, Maggie, for the introduction. As Maggie said, I worked at BC Children's Hospital with her for many years, and recently I've started working at CF Care BC, a health improvement network in our province of British Columbia. I have no relationships to disclose. So as a brief outline, we're again having another history lesson today. I've divided this talk into 3 parts. We're going to dust off this old VCR to guide us. First of all, we're going to do a quick rewind to look where we have come from. Then we're going to press pause to see where we are now. And finally, we're going to fast forward to see what the future has in store. So we're going to start by pressing rewind. Isaac Newton once said, "If I have seen further, it is by standing on the shoulders of giants." And although today I'm presenting a very quick overview of some of the research, I want to recognize the rigorous science that was done by incredible researchers and clinicians, the giants in this room and beyond, to build a body of evidence for airway clearance and ultimately advance our profession. So, back to the quote that Karen said earlier, cystic fibrosis was first described in the 1930s in a landmark paper by Dorothy Anderson in 1938, but as early as the 17th century, this expression was known, "Woe to the child with a salty kiss, for he will soon die." The CF gene was discovered in 1989 in Toronto, but it would take some time before the structure and function of the CFTR protein, its mechanism of action, and the physiology behind the defect was understood. It was known early on that this cystic fibrosis involved the production of thick and sticky mucus in the lungs. Postural drainage, percussion, and vibration is the historical traditional treatment for cystic fibrosis. This early treatment was known as the ketchup bottle method. It involved putting the individual in gravity-dependent positions to allow gravity to drain the secretions and apply clapping to their chest wall to shake loose those secretions. It was understood that cystic fibrosis was a disease of mucus obstruction, even if the specific mechanism wasn't understood. It was thought that by clearing the mucus through mechanical percussions, you could improve mucus clearance, optimize respiratory health, and ultimately slow the progression of the disease. A few studies showed improved outcomes in CF with this treatment, but it wasn't long before it was considered such a standard of care that a study which included a control group with no treatment would be considered unethical. Typically, airway clearance is introduced at the diagnosis of CF. Historically, this was after the onset of respiratory symptoms, but now is usually made within the first 2 weeks of life due to newborn screening, and hence some of the newborns are asymptomatic, or I could say pre-symptomatic. Since the discovery of the CF gene and the structure and function of the CFTR protein and the 2,000 variants of the gene, decades of work has been put into understanding the pathophysiology of lung disease in CF. CFTR is not functional. The flow of water out of the cell is impaired, causing excessive mucus that's dehydrated, thus causing decreased mucus clearance, leading to mucus obstruction and plugging. This leads to inflammation and infection, which causes bronchiectasis, airway damage, and loss of function. Airway clearance removes these secretions through mechanical means, and it was historically called chest physiotherapy, but has since evolved to use the term airway clearance. Ultimately, the goal, as I've already said, decreased progression of lung disease. Research into the efficacy of chest physiotherapy progressed during the 1980s. It started looking at single sessions of treatment. Weller showed that chest physiotherapy improved peak flow in a single day. Other studies showed that chest physiotherapy increased sputum produced, and some studies using radioactive tracers showed that chest physiotherapy improved mucus clearance. In the 1980s, Catherine Desmond and her team looked at both the short and long-term effects of chest physiotherapy in cystic fibrosis, and little improvement was seen after a single session. However, they found that after withholding chest physiotherapy in 8 patients with CF for 3 weeks, there was increased airflow limitation. These limitations were partially reversed when chest physiotherapy was restarted, even after 1 session. Maxwell looked at the efficacy of the mechanical percussor shown in this picture to increase independence in adolescent patients. It was found to be equally as effective as manual percussion and in fact preferred by the teenage population. PEP therapy and high-frequency chest wall oscillation were introduced in this era. Autogenic drainage, although first described in 1967, became popular during this time, and chest physiotherapy was seen as perhaps the mechanical approach to anti-infective therapy. In the 1990s, we saw the shift to compare different devices, and this is just a brief highlight of many of the comparisons that were made, and much of the outcome measures of this research were mucus clearance, lung function, and pulmonary exacerbations. In the early 2000s, Dr. Brenda Button, who's at the conference today, and I'm not sure if she's in the room, changed the standards of practice by completing a study, a five-year study of 20 infants with CF. They were randomized to a standard physical therapy group with percussions and vibrations, which included head-down positions, and a modified group without the head-down positioning. It was thought that the head-down positioning increased gastroesophageal reflux in infants with CF, as a previous study had showed an increase in GE reflux. After 5 years, the modified physiotherapy group had fewer respiratory complications, so it was seen to be as effective as the standard physical therapy and in fact protective against the harmful effects of GE reflux. This standard of care is now to use the modified positions when doing postural drainage, percussion, and vibration. Similarly, Maggie McElwain, who's the chair of our session, led her Canadian team to complete the first long-term randomized controlled trial comparing high-frequency chest wall oscillation to PEP therapy and found there was higher pulmonary exacerbations in the high-frequency chest wall oscillation group compared to the PEP group. And since then, we've learned much about this, and perhaps it has to do with the methods of the VEST protocol at the time without including a huff and cough. Over time, we saw an increase in life expectancy. We saw a quote-unquote aging population as clinics increased from childhood to adolescents to young adults. The population got older, and what was a disease of early childhood now had individuals living to young adulthood in their mid-20s. Research was small in numbers, and we have to remember it was done on children. The research was of variable quality due to numbers and design, and we have to remember crossover designs could not be used to complete meta-analyses. So this is just a picture of the Canadian registry data from 2021 and shows the increasing median life expectancy. And we have to remember that in the year 2000, the life expectancy in Canada was still under the age of 35. So looking back, what did we have? A growing but limited body of evidence. But airway clearance was recommended for all individuals for CF. No technique was found to be superior than others, likely due to the small studies, and many airway clearance options became available. We asked big questions. How can we improve adherence? How can we decrease burden of care? How can we improve life expectancy? And what role does exercise play as an adjunct to airway clearance? The James Lind Alliance is a nonprofit organization in the UK that brings together patients and clinicians to prioritize so that health funders and researchers are aware of the issues that matter most to individuals who will benefit from the research. These are the priorities that I've highlighted from 2017 that are pertaining to us. The number one being, what are the effective ways of simplifying the treatment burden of people with CF? What therapies can prevent the progression of CF? How can we motivate and sustain adherence? And can exercise replace chest PT for people with CF? But as we all know, things have changed since then. So to quote Elsa, in 2023, we are heading into the unknown. So much like this foggy bridge in Whistler, BC, we don't quite know where we're headed. We all know that we're in a new era of highly effective modulator therapy. Ivacaftor, ETI, has been approved in many parts of the world. When I published the slides for this talk, ETI was approved for ages 6+ in Canada, and since October 2023, just a couple weeks ago, it was approved for ages 2+, and we're excited to get our 2 to 5-year-olds started in the next little while. The map on the screen is from an important paper by Zampoli and Morrow published earlier this year showing there are still large parts of the world with large CF populations who do not have access to modulators, shown in red, while the green countries do have access. Keeping this in mind, we still have individuals who are ineligible for modulators and for those whom the response is less than desired. And the physiology of CF is changing. Modulators rehydrate the airway surface liquid by correcting the CFTR defect. This has been shown to alter the microbiome and shift the sputum bacteria towards a healthy biodiversity, and perhaps that's just because we're unable to sample in the same way. It had also made pulmonary exacerbations harder to detect and created new challenges for CF clinicians. So currently, airway clearance remains a standard of care for CF across the board. The CF Foundation, according to their website, reviewed their 2009 airway clearance guidelines and found that no update was needed in 2021. And CF Canada is currently undertaking a review of their guidelines. The real-world effectiveness of airway clearance in children was looked at and published earlier this year in the European Respiratory Journal based on their Project Physio, and they're again collecting real-world data on airway clearance techniques in a longitudinal observational cohort study that uses remote monitoring electronic devices in 4 commercially available airway clearance devices. And they found that quality of airway clearance matters the most and showed that airway clearance techniques are beneficial when performed as recommended. Similarly, as mentioned by Karen, we have some information that's coming to us through real-world studies of modulators, and one example is the CAN Impact study, who's collecting information on airway clearance through chart review. We can learn a little bit from STORM and SIMPLIFY and these withdrawal studies for mucolytics, but there are no current airway clearance withdrawal studies, and so there's no evidence that we have to change airway clearance yet. But what we do know is that patients are beginning to stop their airway clearance on their own, and some have suggested that adults are doing so a little bit more than children. So similarly, through a knowledge exchange program with CF Canada, we sent out a brief survey to the PTs and RTs in Canadian clinics about their current use of airway clearance techniques. And so what we found is that some clinicians are recommending a decrease in airway clearance at about 35%, but you can see there's a large range. And more interestingly, but not surprisingly, clinicians agreed that patients are decreasing or stopping their own airway clearance. This leads us for the need to have strong clinical decision-making pathways that if we are to decrease airway clearance, we need to factor into our decision-making. When we asked the clinicians what factors would they use to hypothetically make this decision, these were the ones they selected. A positive response to modulators, such as a decrease in sweat chloride, increase in lung function. Lung function, is it stable? Did it improve? If so, by how much? Lung imaging, is there bronchiectasis? A small amount? Has it been stable? How long have they been on modulators? 6 months, 1 year, have they been stable? At what age did they start modulators? How young were they? Has there been a decrease in sputum production on a daily basis? What is their baseline microbiology and has that changed? And also patient requests and adherence to these therapies. We asked the clinicians what they wanted to know, and they asked some really good questions. Is there a recommended time frame for when it's considered acceptable to step back? Is once daily airway clearance adequate? How frequently should clients be seen in clinic when stable on a modulator? Can kids on modulators stop doing airway clearance if their lung function remains above a certain level? And most importantly, which criteria are important to determine who can stop, who can decrease, and who should not? The answer is we don't know. Again, This modulator therapy has changed care, but not for all. We have no updated standards and we have no withdrawal studies, but patients are making their own decisions. So now we're going to fast forward and see what the future has in store. So in terms of lung physiology, we hope that this group for whom modulators are not accessible will remain small, and we also hope we'll have a more clear understanding of the group that gets less of a response to modulators and perhaps why that's happening. The most significant change that will happen looking forward is that we will have more people who have early access to modulators. The target is moving younger and younger across the global population, and this may mean that we can prevent structural lung changes, there will be less bronchiectasis, and we will learn more about the reversibility of early lung disease. We will be dealing with a different condition. The pediatric population will likely remain the same size unless the birth rate changes, and we are going to get larger and larger adult clinics. And there's much we don't know about pulmonary exacerbations. We no longer know what they look like in terms of mucus production and symptoms. We know that some of the bugs remain, but maybe they're not having the same pathological effect. In 2022, the James Lind Alliance sought to refresh the priorities that they'd set up previously in 2017, and there's a distinct shift in the priorities we're seeing. So again, I just highlighted, as expected, the number one priority being what options are available for those who are not able to take the current modulators with the rare mutations. Number two is the challenge that we're seeing in the absence of sputum and why our airway clearance is a harder sell for us as clinicians. What is the best way to diagnose the lung infection when there's no sputum? And moving from the number one spot in 2017 down to number 8 is how can we simplify the treatment burden? So patients are still looking for ways to continually decrease the burden of care for their chronic condition, and the burden that remains is airway clearance. So the big question remains, is airway clearance still needed, and will it be needed in the future? And I think if I surveyed the room, the answer would be yes. However, it may look different, and it may mean that we are prescribing and instructing our patients as we never had before. Will it be needed by all? How often? Daily or only when unwell? What can we learn from withdrawal studies? If you are young and asymptomatic, or will you need airway clearance, or only as you age and evidence of lung disease is found? What is the role of exercise? Will we be able to say with confidence that exercise is no longer just an adjunct, but can instead, for some people, replace it? The future is exciting. What can we learn from registry data? And how do we collect it now in a way that is going to reflect the meaningful change in the future? Ultimately, we need personalized medicine, and it was summarized well in the Cochrane Review, authored by Maggie and Brenda Button and their team. Airway clearance must be individualized throughout life based on developmental stage, patient choice, pulmonary symptoms, and lung function. Every individual with CF is going to be different, with different challenges and needs, and it underlines the roles of clinicians to understand why you prescribe airway clearance, how ETI has changed or is changing the basic physiology of the airway, and balance the burden of care with the benefits of airway clearance. So ultimately, as we look forward to the big unanswered questions of the future, I will move from Elsa, who's looking into the unknown, to the words of a famous song. I can see clearly now, the rain is gone. I can see all the obstacles in my way, and we can all finish it. Gone are the dark clouds that left me blind. It's going to be a bright day for the CF community. And this is my bridge that was full of clouds, and this is the same bridge you can see on the sunshine. So I want to thank you, and I want to thank my team at BC Children's Hospital and CF Care BC, and I'll open it up to any questions. And I'll start by saying, unfortunately, I did not answer the question that came up after the last session. So we still don't know.
Thanks, Melissa. That was an excellent overview, and I'm really glad you used VHS to look at it, because if you use Betamax, that went
it would have gone over some people's heads.
Yeah. So how are you managing these patients? Because they're doing their own thing. And we know that we're looking at patients, they may not have minimal bronchiectasis, they may have normal lung function, normal lung clearance index. So what are you advising?
We had that really nice discussion for those in this room that were able to attend the airway clearance course yesterday. And so I think across the board, it's like we don't have the answers. And we're watching and seeing, because some patients, no matter how much you tell them to do airway clearance, are not going to do it, and that's a reality. And so I think if you are transparent with them, show them their lung function, watch them over time, then we can make decisions together that's the best for their care.
Okay, thanks very much. And I guess to Maggie, did you ask the question, who's advised patients to stop physio?
Sorry,
That's part 2 for Maggie's crowd survey.
sorry. What was your question again, Mark?
Who in the room has advised their patients to stop chest
I
airway
will
clearance
ask
technique?
that. You're ahead of me, so
Okay,
we'll ask that
I will
question right
I
now.
will shut up.
So, who in this room, and we'll go again with a mild lung disease that have got no they say they don't have any sputum production, have said to their patients, let's stop airway clearance and see how you do? Mark, you do?
Just one patient, but had a normal CT and normal lung function with no evidence of structural lung disease.
Okay, great. Thank you, Mark. Interesting that we get such a variety amongst the audience. I'm sure some people will say that they would never advise any of their patients to stop airway clearance, whereas some people would say, yes, it's okay to stop airway clearance. Talking about CT, Mark, we have a question on our top here, and says the current CFF recommended routine imaging is chest X-ray. However, the gold standard to assess bronchiectasis remains a CT scan. Do you see the role of CT scan playing a larger part in guiding decision making when it comes to withdrawing therapies?
I mean, that's a good question. I think that it's showing a family a picture and showing the actual evidence of lung disease, because you can't really see it on the X-ray, will be helpful and encourage people to do it so they can actually see the tangible things. It can sometimes be a harder sell to have a CT scan done, so it will just depend.
Okay. Another question, which I'll add a little bit to it, is there any information on how the role of huffing can change with patients on ETI in light of improved hydration of the airway surface with thinner mucus? And just to go on with that one a little bit here, how do you ask patients to check if they've got secretions?
Well, it has been challenging because some patients are really dry, but my counter argument is that often in pediatrics, they're dry. So we're trying to teach them more to like hork up to try to get a really good sample. So we teach them to huff, to cough, and then kind of pull up some secretions, thinking that all the oropharyngeal secretions will have contaminated the whole upper airway to see if we can get a good sample. And so a huff, if you can do a kind of a huff without any cueing, you can sometimes hear secretions right off the bat, and that can be useful. And sometimes leading them through a cycle of like active cycle of breathing or autogenic drainage can help kind of loosen up some secretions that you could potentially sample. So I agree, it is a challenge.
Yeah, okay. And the question, Kim, is what is the James Lind Alliance?
Oh, I mentioned it in there. It's like a group from the UK that just sets priority partnerships for their research in the UK.
Do you know how they interact with patients, or how does it work?
I don't know.
Yeah. Just it was a question.
You can look it up. They do it for a whole bunch of different diseases, and they have working groups and meeting groups and set priorities together with their patient partners.
Okay.
I'm from the UK.
It'll be better.
I don't represent the James Lind Alliance, but it is exactly that. It's a partnership between the patient community and professional communities, and a sort of standardised process by which they define research priorities for a whole host of different areas. It's not specific to CF or respiratory, but that priority setting was.
Yeah, thanks so much.
Thanks. And just one other question about exercise. How do you see the role of, or what do you see the trends in exercise as people doing? Are they doing more exercise and less airway clearance techniques, or what do you see the trend?
I'm not sure what the balance is, but I know the ones that are exercising say they feel better exercising on modulators than they ever have before, which has made them participate more. But I don't want to do any spoilers because I know that's what the next talk's actually on.
Yeah, so we're going to segue in there for Don. And as he's coming up, we just want to take another survey.
Yes, thank you. Yep.
So raise of hand, how many of you guys at least say we can switch from traditional airway clearance to exercise as your airway clearance technique?
Oh, quite a few. Okay, so that leads us into Don, and so we welcome Don Uhart. He is a consultant and an honorary reader in pediatric respiratory medicine at the Royal Hospital for Children and Young People at the University of Edinburgh. Don has been working in exercise physiology for quite a while. He did his training at Great Ormond Street in the Royal Brompton Hospital, and he is a joint investigator in a new trial that's happening in the UK called Exact CF trial, which is looking very much at just what we asked, exercise as an airway clearance technique. So welcome, Don.
Thanks very much for that lovely introduction, Maggie, and thank you to the organisers for asking me to come and speak today. So I'm going to talk about reframing exercise and airway clearance post elexacaftor, tezacaftor, ivacaftor. I'm going to refer to that as ETI from now on. Right. Enter. Okay, sorry. Sorry about this. Yeah. So in terms of my disclosures, I have no real conflicts of interest in regard to this talk. So the themes that I want to cover in this talk, I want to cover three themes. I want to think about ETI as a performance-enhancing drug and give some tips to how we might improve exercise performance with ETI. To think about ETI as a promoter of weight gain as fat mass, which I think we're all experiencing in our ETI patients, and to think about the importance of exercise as part of a healthy lifestyle. I will cover that in brief because Jennifer is going to cover that in far more detail after me. And also to cover airway clearance post-ETI and the role of exercise as an airway clearance technique. So first of all, really just thinking about exercise performance and does it matter and why does it matter? Perhaps the starkest reality is that it matters because the fitter you are, the longer you live. And we've known about this for many years, going back to work from Pat Nixon and David Orenstein. But the largest study looking at the prognostic effect of exercise performance, covering more than 400 patients, published by Helge Hebestreit and the European CF Society Exercise Working Group, showed that those with a high level of physical fitness were likely to be alive 15 years on, whereas those with a low level of physical fitness had a significantly higher morbidity and mortality. Morbidity in the form of lung transplantation or mortality. But of course, these data precede the widespread availability of ETI. More recently, in the last week, we've had some work published from Tom Radker and myself, and these data precede the widespread availability of ETI also. But these data show that in advanced CF lung disease, so those with an FEV1 below 40% predicted, that the maxims of the Hebestreit study hold true also. So those with a higher level of physical fitness measured by either peak VO2 or peak work rate are much more likely to be alive, whereas those with a lower level of lung function are likely to have died or required a lung transplant. So exercise performance does matter. What we don't know is how that relationship's been modified by the availability of ETI. So thinking about ETI as a performance-enhancing drug, or I might call this slide, taking anabolic steroids and sitting on the couch eating pizza does not an Olympic weightlifter make. The point I'm trying to make here is that it might be a performance-enhancing drug, but it's only going to enhance performance if you train. And how might you have a rationale for improving your exercise performance with ETI? Well, we know that CFTR is expressed in bone and muscle, and so CF's been proposed as having an integral muscle defect for 25 years or more. So if we have improved CFTR function, then we have the availability to lay down new muscle to improve skeletal muscle performance. We also can maximize the training benefits within the exercising muscle as a result of that improved CFTR function by upregulating our mitochondria and our enzymatic activity to be more efficient at energy transformation. So we've got better muscle trainability. So if we just think about that in a little bit more detail, we've got improved oxygen delivery to exercising muscles. We've got better lungs on ETI. I think that's in no doubt. But we probably also have the potential for improved oxygen utilization by those exercising muscles because we can acquire extra muscle bulk and we can more efficiently transform that energy in the exercising muscles with improved mitochondrial function. But those latter two require training in order to be realized. So there is a potential for improved oxidative energy generation in those on ETI therapy. And if we have more efficient oxidative energy generation, we have a later switch to non-oxidative sources of energy. So there's a later switch to anaerobic metabolism, a later onset anaerobic threshold. And that's part of more efficiently exercising. So if you have a later onset anaerobic threshold, you can acquire a higher exercise capacity and a greater level of exercise performance. So just as a case example, these data also predate ETI, but this is a young man that I look after who presented as deconditioned at one of his annual review exercise tests. So here with an anaerobic threshold coming on at around 40% of his predicted VO2 max, he had a lower than expected peak VO2. But with a 16-week training program, we were able to improve that physical conditioning, anaerobic threshold increasing up to 50% VO2 max, and a concomitant improvement in his peak VO2. So you can see after a training program, he went from about 38 mils per kilo per minute up to 43 mils per kilo per minute. So about a 10 to 15% improvement in his exercise performance. So what's happened in the real world with ETI? We really don't have a great deal of information here. We have some work from the UK looking at cardiopulmonary exercise testing results before and after ETI initiation. Only a 6-week interval here, but they did demonstrate some improvements in peak VO2 and also the VO2 at AT. This was only in 3 patients, so it's really small data. And one note of caution is that we're measuring VO2 in mils per kilo per minute here. So if our weight goes up, we might be underestimating the improvements in exercisability that are seen. And one thing that we know about ETI is that the weight's going to go up. Some work from Israel looked at 7 subjects who performed cardiopulmonary exercise testing before and 2 years after ETI initiation. They didn't show any improvements in peak VO2, at least statistical improvements. They did show an improvement in the onset of anaerobic threshold that occurred later, and some improvements in ventilatory efficiency. But this study didn't have any exercise training offered to subjects, and physical activity levels weren't measured. So there's potential confounding factors here. So I think when we summarize ETI as a modulator of exercisability, it may have the potential to improve physical fitness, but it's unlikely to have a standalone role. Regular exercise is of high importance post-ETI, and exercise training may facilitate the realization of the performance-enhancing benefits that ETI has to offer. For that to happen, it would need to be a combination of strength and aerobic exercise, and of mixed intensity, both endurance and some high-intensity training to achieve the maximum benefit. So the next theme I want to concentrate on is ETI, a weight-promoting drug. For all of us, the balance of calories in versus calories burned is important, but for people with CF, this has never been more important. As I say, I'm going to touch on this in brief because Jennifer's going to cover this in more detail. But when we look at the 12+ trials, we can see that in the F508del minimal function group, this is a 6-month trial. We had weight increases of 2.9 kilos. We had BMI improvements of more than 1 kilogram per meter squared. And in those who were homozygous for F508del, weight went up by 1.6 kilos, BMI by 0.6 kilograms per meter squared in only a month. So there are nutritional gains that are being seen. And in the childhood trials, a 24-week open label study in children, we might expect children in that 6 to 11 age group to gain weight at about 2 kilos per year. We gained weight by 3 kilos in a 6-month trial, and BMI went up by 0.3 of a Z score. There's also a placebo-controlled trial, a 24-week phase 3 trial in 6 to 11-year-old trials. Interestingly, no data in that paper or in any supplement, online supplement is available for weight or BMI. So I can't tell you what happened within that. We know that in the real world, body mass index is increased in the real world data from the PROMISE study. And post-licensing, the numbers of patients approaching overweight is far greater than at the beginning of the study. So I think taking these things into consideration, we can see that weight and BMI go up. There is a story beyond BMI, which is about body composition, the gains in fat mass versus gains in fat-free mass, the concept of normal weight obesity, the lived patient experience about how they gain weight and the body image effects. And Jennifer's going to cover these in the next talk. So when we think about exercise in ETI, I think weight regulation requires a balance of calorie intake, what we eat, calorie expenditure, exercise. We've all got our Excel spreadsheet of ins and outs for that. The WHO offer recommendations of physical activity. They apply to everyone, and I think for healthy individuals with CF, these are the best recommendations to turn to for physical activity. So the message is there for people with CF, the same as it is for all of us. Put down the pizza and do the hard yards. Knowing what's good for you is easy. Doing what's good for you is much harder, but it's always rewarding. I often say to my patients that, you know, I never regret going for a run, even when it's been raining or it's been cold or it's been horrible weather. But I often sit there regretting the fact that I didn't go for a run because I couldn't be bothered for whatever reason. So exercise, I think, is something that is always rewarding. Which brings me on to my real passion, and the talk for the crux of this talk is about exercise as airway clearance. As has been shown from the James Lind Alliance data that Melissa presented, it's a key question for the post-ETI era. And it's a subject dear to my heart because I've been working this project up over the last 5 to 6 years. And the project is exact CF exercise as an airway clearance technique in people with cystic fibrosis, and myself and Zoe Sainer from Portsmouth, Southampton are the lead investigators on this trial. So we know that exercise is an important question for the CF community. As we heard, the James Lind Alliance, it's a shared group of clinicians, allied health professionals, people with disease and caregivers who priority set research questions. And the question of whether exercise can replace chest physio was a key question from this. We also know from survey data that people are already, at least some of the time, and in some situations, replacing airway clearance with exercise, both in data from the UK and also from Australia. We know that chest physiotherapy or airway clearance is a recommended therapy. It's a mainstay of treatment, considered essential for all, ideally starting from diagnosis. Again, Melissa highlighted this in her talk. But it's also seen as a burdensome treatment. It's probably after pancreatic enzyme therapy, it's the thing that people least like doing when they have CF. So when we think about traditional airway clearance or chest physiotherapy, I just want to conceptualize this as a two-step model. So we have step one, that's the loosening and moving of secretions within the airways, and that relies on perhaps a device, a PET mask, an aerobica, an a cappella, or a technique, autogenic drainage, active cycle breathing techniques. Then there's a step two, that's some assessment breaths. Are there secretions there? You might call them check huffs. You may have other names for your assessment breaths. And then you follow that on with some huffs and coughs to facilitate expectoration of those secretions. So what evidence might there be in favor for exercise as airway clearance? We know that exercise improves the ease of expectoration. Tiffany Dwyer's group in Sydney showed this more than a decade ago. It also makes our sputum less viscous. We get a change in sputum rheology. So it's easier to expectorate after exercise. And work from Alexandra Hebestreit probably shows why that might happen. There's some electrolyte change at the airway epithelium, so that exercise is perhaps an effector at cellular level of improvement in ion transport. So when we compare exercise with chest physiotherapy on a head-to-head, again, we're relying on Tiffany's work for this. Treadmill exercise showing the exercise is as effective as the Flutter device in augmenting airway clearance. And treadmill exercise led to improved sputum hydration, whereas the chest physiotherapy didn't. When we compare exercise versus PEP, exercise is as effective as PEP at clearing mucus from the peripheral airways, but PEP was better at facilitating airway clearance from central airways. So I think the message from that is that exercise can be potentially be an effective airway clearance technique, but only if it's combined with some huffs and coughs to maximize that central airway clearance. So these have all been important in us thinking about how we conceptualize exercise as airway clearance, which we've called EXACT. This, again, is a two-step model. Exercise is the mover and shaker this time of secretions within the airways. And then we combine that with some assessment breaths, huffs and coughs in order to clear secretions from those central airways. But what exercise is best? Exercise isn't one thing. Exercise can be habitual physical activity. It can be structured exercise, whether that's a game of field hockey, whether that's going for a run, whether that's doing weight training. But exercise as airway clearance is perhaps something different. So when we started our first study design, this was really one of the key things that we needed to drill down. And we did this doing a Delphi consensus exercise using CF physiotherapists, physicians, people with cystic fibrosis, and also the caregivers of those with CF. For those familiar with Delphi methodology, we have an expert group to set a set of statements, and we rank agreement on a 9-point Likert scale. If we reach agreement, more than 70% consensus, then we're agreed on that question. If we don't reach agreement, we look to reframe that statement and go back to another round of Delphi. And we went through 3 rounds with this. The paper's there for you all to read, but in short, this infographic describes what we found. Exercise for airway clearance was considered as aerobic activity that needed to last at least 20 minutes and be intense enough that you elicited deep breathing. So you were able to speak, but you couldn't complete a full sentence. And that activity needed to be combined with assessment breaths, huffs and coughs during and or after exercise to maximize that airway clearance. So that's really been important because we've taken that to develop the trial that we're currently running. So that's Zoe on the left along with me. And the study is called EXACT-CF. We're funded by the National Institute for Healthcare Research in the UK. And exercise as an airway clearance technique in people with CF or EXACT-CF, a randomized pilot feasibility trial. And we're running that through Edinburgh and Southampton. It's a randomized 2-arm pilot feasibility trial. It's 28 days duration, 25 subjects per arm. In arm 1, traditional chest physiotherapy is continued, and that's advised to be done at least once a day, with exercise being advised as much as people want to do for health and well-being. The other arm is the EXACT arm. They're asked to stop all chest physiotherapy and undertake EXACT at least once a day, with the caveat being that traditional chest physio is allowed if there's any health reason to do so. We're looking at the feasibility of recruitment. That's number consented versus number approached. And we've achieved about a 45% recruitment. We're looking at retention, number completed all visits versus number consented. We've got a 92% retention in the 50 patients that we've had. The acceptability and adherence to the EXACT intervention, as well as participants and health professionals' perceptions and experience. We're going to use these data to devise a definitive trial. We're also looking at safety. That's change in LCI through to day 28. Change in FEV1 and FVC percent predicted. This is home spirometry measured at 7, 14 and 21, as well as in-person spirometry on 28. We're looking at pulmonary exacerbations, adverse events and SAEs through day 28. Again, these safety data are going to be really important in planning a longer duration study. We're looking at other outcomes, physical activity using a Garmin VivoSmart 4 device. So do both groups spend the same amount of time exercising, whereas only one group is having to do chest physio? Clearly, there would be a treatment burden benefit if that were the case. We're looking at total sleep time, quality of life using the CFQR, mood using the Hospital Anxiety Depression Scale, treatment burden using the treatment burden subscale of CFQR, and health economic measures using EQ5D5L. We're not powered to detect differences in any of these measures, but again, these outcomes will aid planning for a bigger study. So where are we? Well, this is our Edinburgh consort diagram. We've got 174 that are eligible. We approached 50 in Edinburgh. We consented 25. We randomized 23. One actually failed screening on the day. But we have recruited everybody across the whole study, across both sites. Our database is currently being cleaned. We have a data lock planned for November of this year, and we hope to present the findings in Glasgow next year with rapid publication planned thereafter. You can follow us on Twitter. I want to thank you for listening, and thank you for asking me again to come here. There's lots of people I need to thank. Zoe, my joint investigator on EXACT-CF, the CF MDT at the Royal Hospital for Children and Young People, and Dr. Tom Radke, who's coordinator of the ECFS working group with me. Thank you very much for listening, and I'm open to any questions that you might have.
Thank you. Thank you, Don. You know, working in CF for a number of years, we've had Melissa and also we've had Karen talking about the history of CF. And Melissa mentioned how it was unethical to stop doing airway clearance. And here in 2023, we've got a study where we're actually stopping airway clearance. I mean, that's amazing, just where we're going with this. I do have a question for you. That was just a comment. But one of the questions that were brought up was, you mentioned the change in sputum with exercise. Is this true when you're on Trikafta?
I mean, I don't think anybody knows the answer to that. I don't think people have looked at that. I think anecdotally, there are people who feel that they are far more productive with exercise than in any other form of airway clearance therapy. So people who are often dry with chest physiotherapy techniques do seem to produce only with exercise now that they're on ETI. So I think anecdotally, yes, but I think that's very individual, and it's probably very different for each patient. Certainly in the sputum induction trials like CF-SPIT that's been coordinated out of Cardiff, there's been a lot of focus on exercise as a potential thing to along with hypertonic saline to help facilitate sputum induction.
Thanks. Any other questions? Anybody come to the mic or ask us questions? I think there might be another one. Okay.
Yeah, there's one here. It says, you mentioned a change in sputum with exercise. Is this true? Oh, you already just
I just asked that.
It just came up. Somebody pushed it again. So it's a very popular question. So another one would be, would you recommend guide your airway clearance with the modulator changes in the mutation or with the PFT FEF 2575?
Sorry, can you repeat that? Sorry.
Would you guide your recommendation on airway clearance either through the mutation or the PFT on FEF 2575?
So I guess FEF 2575 is going to give us an idea about airflow limitation. I think the mutation, there's clearly such heterogeneity in lung phenotype across mutations. I'm not sure I would use a mutation to guide airway clearance. I guess there could be some usefulness in using FEF 25 or LCI or other more sensitive markers. I'm not sure that at this stage we have the evidence to tell people to stop doing treatments, and that's why I think it's important that we do clinical trials to ascertain what the potential harm of stopping is. I think that's probably going to be the best way to guide treatment going forward, is collecting evidence and then being able to say with more certainty whether it's safe to stop treatment.
Thanks.
Okay, just one more. For the patients only engaging in exercise, have they received coaching or training to ensure the quality of their workout meets your criteria?
I mean, I in the interest of time, I couldn't tell you everything about the study. There is a compendium of information that's given to patients at the beginning of the study. We also use the Garmin device to measure time spent in moderate vigorous physical activity. So we're measuring moderate vigorous physical activity and looking for 20-minute bouts of that, and we're able to feed that back to the patients within the study. But in terms of the advice we give, it's really pretty pragmatic advice about the sort of exercise that we want them to do, and about the sort of level of breathlessness that we want them to achieve, because we think that that's going to get them into that MVPA zone if they are, achieving a decent level of breathlessness with exercise.
Yeah.
So it's really pragmatic rather than.
One of the things when I'm considering exercise for airway clearance, and people who say they're not going to do any airway clearance, but they'll do exercise, is I really emphasize to do the huffing part of it. How important is that in your study?
I think that's vital, Maggie. I think that's the key thing. I mean, I think we've probably known about that for 30 years. Louise Lanifor's work 30 years ago, combining huffs and coughs with exercise. And I think that's vital. I think if you exercise and shift secretions, you need a mechanism to expectorate those secretions. Now, it may be that there are no secretions there in someone who's dry, but if you're doing some assessment breaths or you're doing some check huffs and there are secretions there, then we need to move those on with huffs and coughs.
Okay, thanks. What were the reasons why 50% of your patients didn't want to participate in the trial?
It's a great question. I think some of the. I mean, there are a diverse range of reasons. Perhaps the biggest reason is people not wanting to be randomized to a study that asks them to do more exercise because of work, life factors. People, smaller number of people who did not want to be randomized to a study that considered that they may need to stop chest physiotherapy. A priori, I thought that would be higher in the pediatric age group where parents would be very concerned. It actually seemed more common in the adult age group with slightly anxious adults who were feeling very well for perhaps the first time in 30 or 40 years and didn't want to change anything on ETI. Everybody was on ETI in this study. Yeah.
Okay, thanks. And just last question we'll ask is, it makes sense why aerobic exercise would be the first mode of choice to replace airway clearance, but what do you think about resistance training as an option?
Yeah, so it's a really good question, and through the some work from Australia had suggested strength training and resistance training as being a potential for airway clearance treatments. When we went through the Delphi consensus exercise, there was a fairly strong rejection of resistance training, though I think quite a lot of the aerobic exercises will involve both aerobic exercise and resistance work. Some of the racket sports or rowing or some of the other things. I think maybe what came across most clearly was it was exercise along with vibration and movement. So, running or racket sports or basketball or sports that involved jumping and moving. So it's probably the combination of aerobic exercise, breathing deeply and getting air behind secretions, but also vibration to help move those secretions.
Great. Thank you very much, Don.
Thank you.
Thanks.
I know there were a lot of questions here coming up in our chat. Just so you guys know, the speakers can also go into the app and answer the questions for you for the ones that we didn't get to. So you guys can go into the Q&A section and you can add your response for all the questions that we didn't get to. So we're going to go ahead and move on to the next speaker. And it's Jenny Walzell. She earned her doctor's of physical therapy from the Texas Women's University in Dallas, Texas. She's currently part of the Pediatric Adult Children's CF Center. She is also presenting this similar topic in the roundtable, so you can also join that for more detailed and Q&A for her as well. So we would like to say welcome to Jenny. Thank you.
Hi, thank you, Cheyenne, for that introduction. Like she said, my name's Jennifer, but I go by Jenny quite often. You can call me either one. And I'm a pediatric physical therapist at Dell Children's Medical Center in Austin. For the purpose of this presentation, I do not have any relationships to disclose. All right, so let's get started talking about body composition and exercise and how it relates to pulmonary function. Here's the presentation summary. This is just a new way to look at exercise as part of treatment for CF and as a form of healthy living in the post-modulator era. The objectives are going to take us through the presentation, and I will try my best to focus on the post-modulator era. So when looking at lung function, there are many influences. The type of mutation, drug therapies, as well as compliance to all therapies impact lung function. So as we heard from Don in a previous session, or the previous presentation, exercise is already known to be a form of airway clearance and therefore has a positive effect on lung function. Nutrition status also has an impact on pulmonary function, with the recommendation for children with CF to have a BMI greater than 50% and for adults to have a BMI of greater than 23 to be considered having good nutrition status. Exercise can improve nutrition status by increasing lean body mass through resistance training, and therefore in both ways, exercise can be used to improve lung function. So since highly effective modulator therapy has been introduced, there has been a significant impact on lung function and nutrition status. When a patient starts taking Trikafta, there's a rapid increase in FEV1, which is maintained over time. There are also fewer secretions. Also, with BMI, there's a rapid increase, with the majority of it coming from increased fat mass. Similarly, in the last 10 years, with the initiation of modulator therapies, there has been a steady increase in the obesity and overweight status of people with CF. So this makes exercise an even more important aspect of caring for the CF patient, as it can address both. There is some evidence to support that muscle function improves after starting Trikafta, but not necessarily gains in strength. As Don mentioned, you can't sit on the couch and gain muscle. So there has been this shift in focus from exercise just to a form of healthy living as well. So because not everyone may be as familiar with body composition, here's a quick overview. Body composition is defined as the relative percentage of body mass that is fat and then fat-free. So the fat-free includes muscle, bone, water, and it can be measured in a variety of ways. First, anthropomorphic measurements, they aim to measure the human body using non-invasive measures. So BMI, circumferences, and skin fold measurements. Body mass index is definitely the most common, as it only requires a height and a weight to calculate. However, BMI fails to distinguish between fat, muscle, and bone. Despite this, there are many studies on BMI and its impact on individuals' health. I'll bring up that a little bit more later. So densitometry, hopefully I said that right, is a measurement of whole body density by displacement of water or air. So body composition can be estimated from whole body density using the ratio of body mass to body volume. The underwater weighing is based on Archimedes' principle. The loss of weight in water allows for the calculation of body volume, as bone and muscle are more dense than fat. The negatives to this method are obviously that you have to be completely submerged in water, which people do not want to do. Or plethysmography uses air, but you have to have this very fancy machine. So then we have bioelectrical impedance analysis, or BIA. This sends electrical currents through the body to measure the impedance. Without getting into the physics of it, essentially different body tissues allows for faster or slower movement of the electricity through the body, and therefore can tell how much of your body is fat and how much is fat-free. The benefits of BIA are that it's relatively fast. It's slower than a BMI calculation, but faster than the rest. It takes just a few minutes to administer and is completely painless. It does require specialized equipment. There are variable accuracies of these equipment, and it's also dependent on following protocols for hydration status. DEXA is currently our gold standard for body composition analysis. It can be used on any age or size of person, and it gives accurate analysis of fat and fat-free tissues. There's also reference data that exists to provide Z-scores for multiple data points. The limitations are that it requires highly trained personnel, and there's a high cost to this as well. So as I was saying earlier, in people with CF, nutrition status matters for lung function. Specifically, there's a positive correlation between BMI and FEV1, with a higher BMI indicating higher lung function and a lower BMI indicating lower lung function. So why is this? So far, the why is really too complex to understand clearly. We have the chicken and the egg. Do we have poor nutrition status because we have poor lung function? Or is the poor nutrition status contributing to poor health and therefore poor lung function? At rest, our bodies require a certain amount of energy to function. This resting energy expenditure and BMI are inversely related. So generally, the more severe a person's CF is, the more likely they are to be underweight. But also, the malnourishment may accelerate the progression of the CF disease. This also doesn't take into account those with CF who have pancreatic insufficiency or other GI-related concerns. So regardless of the why, what we do know is there is an impact of muscle on those with CF. So if we remember, body composition is generally understood as the percentage of fat mass and fat-free mass, meaning muscle and bone. So a low fat-free mass or low muscle mass is associated with lower percent predicted FEV1 and more pulmonary exacerbations in adults with CF. Also, adults with lower fat-free mass or lower muscle mass and a normal BMI have lower pulmonary function than those with a normal BMI and a normal fat-free mass. So this indicates that regardless of BMI, these same principles apply and speak specifically to the importance of muscle mass over fat mass. But this also brings us to the obesity paradox. So for the general population, BMI that classify as overweight or obese are associated with poor health-related outcomes. However, a recent systematic review demonstrates that in those with CF, having a BMI of greater than 25 actually have a better FEV1 compared to those with a normal weight and have less risk for pancreatic insufficiency or CF-related disease compared to those with normal weight. So this really doesn't contradict the theory that muscle mass plays an important role in body composition, as BMI doesn't allow for that separation of fat and fat-free tissue. But there is, so it is possible, though, that those people who are overweight may have more muscle mass as well. But this really calls for more research in this area, which I will speak on more later. All right, so how do we help our patients gain muscle? So it takes 12 weeks of consistent resistance training to see true gains in strength or muscle hypertrophy. The ACSM recommends 2 to 3 days a week for each major muscle group and a 48-hour rest in between those muscle groups. So the intensity should be moderate, but strength gains have been seen in light resistance training, but that would be more like 40 to 50% of your max. And those who are sedentary, so if they're just getting started, they can start low. Although no specific amount of time is required, there is a general recommendation for like 3 sets of 10 reps with a rest of 2 to 3 minutes in between sets. So to gain muscle, you need enough calories to support this. It makes it harder for our CF patients who already struggle with calorie intake to gain muscle. There is also the impact of hormones as well. So testosterone plays an important role in muscle development, which is why before puberty, it is difficult to gain muscle. And it also explains the difference between males and females in the adult population for the discrepancies in muscle mass. So other benefits of resistance training for all populations are increasing bone mass, reducing risk of developing pain and other musculoskeletal disorders, and can prevent or improve symptoms of anxiety and depression. It is commonly said that if exercise was a pill, everyone would take it. So as I said earlier, there's a need for more studies on body composition and the effect on lung function in CF. At our center, we started a study that I hope to complete by the end of 2024 on body composition. These are very preliminary results of the data collected in the last year, with more to come in the future. Our center uses a BIA machine. It's called the InBody, so I'll probably refer to the InBody from here on. The adult team in Austin trialed this first, and then we as the pediatric team just started using it in the last year for the younger population. So as this is a new piece of equipment, only a few patients had completed the InBody twice in the past year. There were 12 patients who were included in this small sample, with all but one of them being male. Of note, our center is actually majority male. We have 52 or 55% male at our center, so it being the majority is not surprising. Our average age was almost 16 years old, with 9 of them being on Trikafta, 2 not on modulators at all, and 1 actually started between their first and second. So the InBody is performed by a care team member. Typically, it's our registered dietitians, but can be performed by anyone who has been trained. The results are typically provided by the same clinician to the patient. We really focus on the results on the lean muscle mass, and we try to avoid discussing fat mass. We just don't want the focus to be on fat, as this can lead to body insecurity and an unhealthy goal of concerning weight loss. We work with many teenagers who already have issues managing their weight, and we don't want to give any data that can disrupt their mindset. Our goal is to perform the test every 6 months. This allows time to make changes. More frequently wouldn't really allow that time, as it takes 12 weeks of consistent strength training to see changes in muscle mass, as I said earlier. Okay, so lung function here is just defined as their FEV1. So the post-FEV1 is measured at the date of their second InBody, and the pre-FEV1 was taken from the year prior to that in the same season. The reason being, lung function changes seasonally, with lower lung function in colder months and higher in warmer months. So to better compare, we use the lung function from the year prior. As you can see, the average increased by 0.28 or 9%. And currently our sample size is too small to calculate significance, but we can see there is a clear increase. For skeletal muscle mass, comparing the first InBody measurement to the second 6 months later, there was an increase of 4.75 kilograms of muscle mass based on the average of the 12 subjects, with a relative change being almost 8%. Again, we don't have enough data to calculate significance, but there is a steady increase. So just a few case studies. One patient did start exercising between their first and second in-bodies based on the recommendations of PT in clinic. Their skeletal muscle mass increased by 1.3 kilograms, and they are not on modulators. Another patient started on Trikafta between the first and second in-body measurements and had a muscle mass increase of 6.4 kilograms. And this was not even the greatest gain. So our second largest gain was made by a patient who wasn't on modulators either, with an almost 20% increase in muscle mass over 6 months. Pretty impressive. So there were several limitations to this study. First, there's no discounting the amount that genetics, exercise, and hormone changes can affect the amount of muscle mass gained by an individual over time, which we could not control for. We also have a small sample size, although if we included all of those in our study who are greater than 13, we would have roughly 60 participants. So I think I calculated it out. This captures about 20% of our center. Right now, we're not controlling for hydration status, which can affect the results of the in-body. And lastly, at this time, we do not have a standardized script for providing information on the test or the results. So our initial results indicate that the in-body is a time-efficient method for measuring body composition in clinic. And so far, with our limited samples, just providing the results on skeletal muscle mass with this small sample size, we can see there is improvements. All right, so next steps, we need to start controlling for hydration status, develop a standardized script or handout for discussing the results of the in-body. We need to define our cohort and looking at modulators versus non-modulator therapies and making a definite exclusion criteria. Increasing our sample size will allow us to make conclusions and make significant results. And finally, we've got to submit an abstract, hopefully next year. So in summary, exercise leads to improved pulmonary function by improving lean body mass and in some cases increasing BMI. Exercise is beneficial to people with CF by improving pulmonary function through airway clearance, improving nutrition status, as well as all the other benefits of exercise. These include improving bone mineral density, mood, sleep, quality of life, hormone regulation, and decreased risk for heart disease, hypertension, and diabetes. Is my work cited? Any questions?
So here's some questions. What was the exercise program of the person that gained 18% muscle mass? That is an impressive improvement.
It is. Well, and also remember, these are also teenagers, so they're gaining a lot of muscle mass anyway, they're growing a lot. I didn't ask their exact method, but I should go back.
Okay, thanks. How do you control, were any of your patients on steroids, anabolic steroids?
I don't believe so. Again, I'd have to go back and double check, but I'm pretty sure they were not.
Okay, all right, thanks. And also, have you looked at bone density with the changes with starting on ETI at all?
So with the BIA machine, it doesn't actually look at bone density, so we would have to do the DEXA for that, which requires more time, more money. But I definitely think it's worth looking into. I would love to do research on that.
Yeah. Okay, great. Thanks.
Okay. Is the BMI valid in CF? I'm assuming post-modulator body water is fairly similar to non-CF population.
Say that again.
Is BMI valid in CF? I'm assuming post-modulator body water is fairly similar to non-CF population.
Well, BMI right now is still the standard used nationally for us as far as body composition goes, just because, like I said, there's a lot of, it's so easy to calculate. You just need a height and weight. But as far as it being valid, I'm going to go with yes, as it's still our standard.
Yeah, I just have an interesting comment on that. In Canada, for ETIs, there are criteria that have to be met for renewal of ETIs on a yearly basis. And in one of our patients, who's a teenager, they were denied renewal of their ETI because their BMI had fallen. And the reason why that BMI had gone down as a Z score was that they had a big, high teenager, a growth spurt. And so the BMI went down and they were refused to keep on ETI. So it's just something that we should be aware of. Yeah, just a comment. Okay, thanks. Go ahead.
Okay. Was there a correlation between the increased muscle mass and FEV1?
Well, yes. It's really, in terms of my study, again, they're very preliminary results, but that's kind of what we're hoping to see is that correlation. The amount that each went up didn't exactly match, but that doesn't mean that it doesn't have something to do with each other. There is research that, right, the impact of muscle mass on pulmonary function is there.
I mean, and where are all the patients exercising before or after their body composition assessment? Any thoughts on whether the majority of the participants were, why they were males, but the majority? So there's two questions. The first one is, where are all the patients exercising before their test?
So I would say that these 12, the boys were already exercising, yes. I don't think it's a secret to say. The female is the one that started exercising between her first and second in-bodies. And what was the other part of that question?
Oh, sorry, the second part of the question was, sorry, I was looking at it. Why do you think, you said the majority, you only had one female. Why could you not get more females?
So again, with our study, we need to set the exclusion criteria because currently we are avoiding those who we think might have a negative response to finding out more about their body composition. So a lot of teenage girls already have body image issues, so we've kind of been avoiding that. But that's part of what we need to do in the study is actually have a set standard of like who is going to be excluded instead of just like, oh, I don't think she'd respond well. Like we need to actually have an outcome measure that distinguishes them separate. So that I think is a big part of why there was only one female.
Okay. Any other questions that we have? I think that's all. Okay. Well, first of all, I'd like to thank all our speakers at this afternoon's session. You can see that we do not have all the answers, but we have a number of trials going on. We're hoping within the next year to have some more studies looking at trying to really define, when can we stop these therapies? When do we need to continue these therapies? And I know that there is a trial coming up looking at that. So thank you all for attending, and thank you, Jennifer, for your time.